All right, we're live.
Good morning. It is February 5th. We're Red Day. This is the Senate Health and Welfare Committee, and where red is particularly significant for us because we're very concerned about prevention and preventing heart disease, particularly in those who are more susceptible. So, thanks all for being here this morning. We have a couple of different things that we're working on. We're going to start out with um, the flexibility bill and some testimony on audio only. And we have on the agenda, you'll see we have some of the insurance companies represented, Blue Cross Blue Shield and MVP Healthcare. We also have Helen Laban of Bi-State Primary Care, and she'll be testifying. And then as we move through the morning, if Board of Medical Practice is available, David Hurley will be talking about something in the bill, not the audio only, from what I understand. So that there's a little bit of a change to the agenda that happens, and we'll just move forward. So Sarah Teachout, welcome.
Good morning.
Good morning. And we have testimony from you about audio only on our webpage. I will say this, I do know that there's been a lot of work done in the interim between sessions on the audio issue, only issue. Also that the House Healthcare Committee is working on this, and we'll be looking at language that they put together, and then we'll discuss with them any modifications that we would like to make. So it'll be a complicated process, but that's the way we work. So
I appreciate it.
Thanks for being here.
Thank you. Thank you, Senator Lyons, and thank you, committee, for taking some time with us to focus specifically on the audio only pieces in your proposal. Blue Cross was part of the work group that met quite a bit over the summer and fall to talk about how audio only care should be addressed after the pandemic is over. And I realize, and I said before when I was talking, that we're in sort of the gray area of we don't really know when the pandemic's going to be over, and we're certainly not in the height of the lockdown, but we're far away from the end at this point. Pre-pandemic, telephone calls between providers and their patients were generally check-ins or providing follow-up to lab results or those types of things. And they generally were not paid for by insurance. And part of the reason for that is that when you go to your regular in-person visit, the coding for that includes some of these other pieces of work that the provider does. So it assumes that there is some work that's not directly involved with the doctor talking to you in the room. So, but we do recognize that during the pandemic, access to their providers, either through audio only or through the telephone, has been critical for our Vermonters across the state. And we very much supported that. And as part of the emergency discussions that we had with DFR in creating this rule, we strongly supported paying providers the same amount for these telephone calls as they would have for an in-person visit. And the reason for that is that we were in a total lockdown, and we recognized that providers very much needed to be paid for their time, and were facing some serious financial hardships during the lockdown. So the recommendations that I provided for you were in the report, but they were buried pretty deeply down on page 56. So that's why I pulled them out and sent them to you again. And they focus on what our concerns about continuing health disparities, the quality and standards of care for audio only care, using the appropriate coding, and then lastly, the cost and payment structure, which is the one area that we had the most disagreement among the stakeholders. It's our belief that audio only care should supplement but not replace high quality in-person or audiovisual care. So just to focus a couple points on the quality and standards of care, what we found, because we heard from a lot of experts over the summer and fall, when we heard from these experts, most of them noted that there isn't a lot of research and there aren't a lot of quality and standards for telephone only care. That's not really something that we've ever done a lot of in the past. And so there's very little work on it. And 2 points that I wanted to make. One was by a world-renowned healthcare scholar, Dr. Donald Berwick. And he noted that there are benefits to telemedicine, but they're nuanced. Providers depend on visual cues and body language signals that are difficult to pick up via telephone. And that the success of a telephone appointment can depend on the patient oftentimes being a good communicator. So that was important to note for us, as well as our clinician, Dr. Kate McIntosh, was very concerned that this could perpetuate the inequalities in healthcare for people who don't have access to their provider via audio visual means or an in-person visit. And she's specifically concerned about audio only care for children, people with hearing issues, and those who have difficulties communicating. So let's see. So I'll jump straight then to the cost and payment structure. Again, I mentioned before, prior to the pandemic, there was little or no payment for telephone only care. During the pandemic, we have been paying providers as if these were in-person visits. And our recommendations are that we set appropriate fee-for-service levels. And one part of that is differentiating in the codes between what is a telephone call visit and what is either a audio visual visit with the visual equipment. So we really do need to differentiate. Right now, the way that these are being coded, we can't tell in our claim system, which is one or the other. Part of that was just done for expediency. We wanted to get this up quickly. And so we didn't require providers to indicate the difference in the way that we coded these. So that's one thing. And that's one of the pieces of language that I propose to you, is not immediately, but giving us a little time to work with the stakeholders to ensure that we can differentiate between these types of care going forward. The next is setting appropriate fee-for-service rates. While we very much support value-based payments, we recognize that the fee-for-service system is ongoing and will continue to go for a while that way, and we feel that we need to have fee-for-service payment levels that are appropriate. Blue Cross does not support paying at the same level as an in-person visit post-pandemic. We would like there to be a differential. We want to recognize that there's a different value in this care, and we want to promote high quality in-person or audio visual care, and therefore we feel that the payment rates should be different after the end of the pandemic. And I think another thing that I would like to mention is that we have heard complaints from our customers about audio only care. I know that you heard from Mike Fisher that some people do like it. We heard predominantly from the people who didn't like it. And there were 2 points. One is that they felt like it wasn't the same as an in-person visit and they weren't getting the same quality of care. And the second was that the ones that had to pay as if it was an in-person visit felt that it wasn't worth the value for them. And the point that I'd like to make here is not just that patients are complaining, but in their gut, they feel that it's not the same type of care and it's not worth the same amount. I think the other thing is when we initiate new programs like telehealth, we talk a lot about the benefits and how this could save money in the long term. But when you require the same payment levels as an in-person visit, it really does prevent us from achieving any savings from these different modalities of care. Let's see. And then the last thing to play into that point is that, Vermonters have a finite amount of resources to spend on healthcare globally. And we don't believe that telephone medical care is the area that we should be spending their resources, that this isn't our highest priority for where to spend money on care. So I won't spend any more time just talking at you. I did have 3 proposals. I can't bring them up on the screen, so I'll just tell you what they are, and they're in your, if they're online for you. One is having us work with the stakeholders in the Department of Financial Regulation to be able to differentiate between telephone only visits and audio visual telehealth visits. And it gives some time for us to work that out and, educate everyone and make a change. So I suggested January 1st, 2022 to give everyone some time to work through that. Open to suggestions, but that was one. And then the second 3 suggestions are consumer protections. One is on cost, so notifying a person in advance of their telehealth or their audio only visit about the price. The second is notifying them that they have the options of choosing between in-person. This is all post-emergency, in-person, audio visual, or a telephone call. And the third is protecting patients' access to the care by ensuring that they can see their provider in a relatively expedient manner via any modality, and not you can see your provider by telephone tomorrow, but you'll have to wait 3 weeks for an in-person visit. We really want to ensure access via whatever choice the patient has. So those are our 3 recommendations for additions to the language.
Okay, thank you. Questions, committee? Senator Hardy.
Madam Chair, and Sarah, thanks for your testimony. This is the first time I'm getting testimony directly on this issue. I just have a couple clarifying questions.
Sure.
About, this sounds really basic, but what is meant by an audio only visit versus just a phone call from your physician telling you about the results of a test, or following up from an appointment you may have had in person, or explaining something to you? Like, where's the distinction? How do you define that?
Right. So I think if we use telephone only CPT codes, the distinctions will be more clear. But there are, for an evaluation and management visit with your physician, there are certain, components to that visit. And we're talking about scheduled medical visits with the provider, not a quick follow-up call. And I think we can be clear about that in the post-emergency legislation. I think most providers, that's the way they've been using this option, but we have had a couple complaints for people who had 10-minute phone calls with their provider and were billed for a full office visit. So,
okay, because as of now, those 10-minute follow-up phone calls would be considered part of the regular visit, right? Or for billing purposes, or not? What?
It really depends on how the provider codes it, to be honest. And when I say provider, I don't necessarily mean the doc is even making that call. Oftentimes it's their office that is, determining that based on the notes about what type of call it is.
Okay. All right. Thank you.
That's not the super clear answer, but I'm trying.
Well, a sort of gray area. I mean, I actually yesterday happened to be on the phone with many, many doctors, and they varied in length and content and everything. And, I'm just thinking about my own, obviously we're all thinking about our own personal experiences, and how would that play out in any changes that may or may not happen. And so just trying to figure out where's the line, and it sounds like the line may be a little gray, but thanks, that's helpful.
So you're right, Senator Hardy, and that becomes the issue, how to resolve this. And we're going to hear next from another representative of MVP, and then we'll hear from Helen Laban, who has some expertise in this. And was also working with folks on the I call it a task force, so working group. So Senator Hooker, you had a question.
Just a quick question. Thank you. And Sarah, CPT code, what does CPT stand for?
Oh, gosh, I should know that. It's the standard, it's a coding system created.
Okay.
There are codes of
I'll send you
procedural
a quick
terminology, something like
Yeah.
that.
Go. What is it, Jen? You
Codes of procedural terminology or something like that.
Codes
or
of
something.
procedural terminology.
I think the PT part is procedural terminology.
So there's a
Um,
code,
Let's
for
see.
the wellness office visit. There's a code.
Current,
Oh,
Part
yeah.
current
And-
three.
yeah,
procedural
Yeah,
terminology.
I just
Yeah,
was
that.
curious to know what the acronym was for. And
Yes.
you
Oh,
did.
don't,
Current-
how could you possibly want to know an acronym, honestly?
It's current procedural terminology. That's
I'm
what it's
sorry,
Current-
again,
Current procedural terminology.
current person. Well, so that suggests that it could change if it's current, right? And your explanation to Senator Hardy about the difference between a phone call and an audio visit is helpful, although I do have to say sometimes in-person visits are only about 10 minutes long as well, and they get covered. So, but I'm anxious to hear more.
Senator Terenzini has a question.
Thank you, Madam Chair. Just a clarification. The audio only proposals we're discussing, is this tied to a proposed bill? And if so, what number would that be, Senator Lyons?
This is our flexibility bill that we were
Okay.
working on. Yeah.
Okay.
So there is that one section in the bill that doesn't have a date certain and really hasn't been resolved on audio
Okay.
only. And when we go through it later with Jen, she can clarify.
I appreciate the clarification. I have bills printed all over my desk here, and I'm trying to make sense of it all. So I want to make sure I'm on the right subject matter.
Now you are.
Thank you.
That's great. Jen, what section is that in the bill? Do you know offhand?
It's the one that I moved out to be a standalone. So in yesterday's version, I think it was section 4. Today it'll be section 3 because I got rid of one of the OPR
Right.
provisions
Okay.
that they said that they didn't need. So it's the one that gets amended by 3 different acts, the most recent being Act 159. And at the end of that, it's at the end of that section, it's broken out in the proposed bill separately. And it
All
has, I
right.
think it currently has a January 1st, 2024 date on it, but that's again part of your committee discussion.
Okay. Chuck Storrow is here representing MVP, and we also have something from you on our webpage. So why don't you introduce yourself for the record, and we'll listen to your testimony.
Thank you,
Are you-
Madam Chair, and
Yeah,
thank you,
you're here.
committee
Okay.
I'm right here. My name is Chuck Storrow. I'm with Leonine Public Affairs, and I'm here on behalf of MVP to talk about the audio only provision. That provision is in the draft legislation that the committee is considering that would extend all of the legislation that was enacted last year. The particular provision is in Bill Section 4, and that's on page 17 of the draft that's posted on the committee's webpage under yesterday's date. Overall, the draft legislation basically would extend, its the various provisions of those 2020 acts until 3 months after the state of emergency is over. But this particular section on audio only is an exception to that sort of time-limited nature. What it would do is instruct the Department of Financial Regulation to consider promulgating rules requiring continued coverage of audio-only healthcare services and reimbursement for those services. That provision would expire, or those rules would not continue in force until after January 1, 2024. And so since hopefully the pandemic will be open sometime this year, the requirements of that section would, and the resulting rules that DFR would promulgate would continue beyond the pandemic. So that's kind of a departure from the norm that's otherwise established in that bill that really limits all of those provisions to 3 months after the emergency over. And it is like Blue Cross Blue Shield, MVP's concern is that while during the pandemic, it may well be appropriate to continue coverage for audio only services at an equal level of reimbursement, The company does feel that that may not be appropriate after the pandemic is over. Specifically, some of the concerns that the company has, which are similar to what Ms. Teachout articulated, are, what is the relative clinical value of an audio only visit in relation to, say, an in-person visit, and should it be, in fact, reimbursed at the same rate because of perhaps a difference in that clinical value. And the thing of it is, it may well be the case that depending on the situation, there is equal clinical value. But there may also be cases where it is not of equal clinical value. For instance, if you go in and see a physician, typically you're going to have your blood pressure taken, you're going to have your heart rate monitored. There will be, the ability to observe the patient in person and see their body language and things like that. Those kind of activities may provide, value from a clinical standpoint. That isn't necessarily the case if you're just speaking to somebody on the phone. Another, factor is it may well be in certain cases, again, not necessarily across the board, it may be less expensive to the provider to provide audio only services as compared to in-person services. As Ms. Teachout indicated, traditionally, sometimes audio only services pre-pandemic were not billed. They're included in, the charge for the in-person visit that, the audio only conversation is a follow-on to. Another thing to, bear in mind on all of this too is that, most people, health plans or their health coverage is subject to deductibles and co-pays, and depending where you are and in terms of working through your deductible, it's going to often be the case that, an audio only episode of healthcare is going to be borne by the patient out of pocket. They're going to be paying for it as opposed to the health insurer. So, those are some considerations that in our mind dictate that there not be a mandate that all audio only episodes of healthcare be automatically billed at the same level as would be the case if it was in person. And so we would, MVP, certainly is amenable to reimbursement at the equal level during the pandemic, and is certainly amenable to the notion that there in fact be a requirement post-pandemic that audio only services be covered. But we don't feel that it should automatically be the case that it's always reimbursed at the same level as a in-person visit or even an audio visual visit. So we've come up to some proposed bill language, and I'm going to try and share my screen and show you what we have in mind.
Yeah, we have it. It's at the bottom of the testimony, I think, that you submitted.
It is.
Yep, okay.
Okay, does that show up?
Yep. There it
Okay,
is.
so yes, it is that last bullet point, and that's the existing language that's on in Bill Section 4 on page 17. The language that MVP is proposing is shown in bold, and basically what it would say is that DFR, in addressing reimbursement for the provision of services by audio only telephonic means after the expiration of 3 months following the termination of the state of emergency, the department shall consider the cost impact of such services to health insurance premiums and to patients' out-of-pocket costs, the clinical value of the services in relation to the clinical value of providing services in person, and providers' costs in providing such services. So what we are proposing is that there be some flexibility on the part of DFR to address this issue in the rulemaking process, to take into account the various variables that bear on audio only, the provision of audio only healthcare services. And I'll just scroll back up. The rule itself that's currently in effect is which was promulgated by the department as an emergency rule in response to last year's legislation is set forth there. And there's the language in italics that sets forth the current standard on reimbursement rate. And it's our concern that while the bill language that the committee is considering just instructs DFR to consider promulgating rules, that in doing that, in the absence of the language that we've proposed, DFR would likely go with what they've already got on the books. And so just wanted to give you that context as to what's sort of out there right now on this issue, and to sort of so you can understand what our proposal is. With that, I'd be happy to take any questions.
Okay, thank you. Questions for Chuck Storrow? Senator Cummings.
It's probably for Chuck and maybe for Sarah. Do any other states pay the same rate for audio only? Or would we be an outlier?
Truth be told, Senator, I don't know. I would not be surprised if that is not addressed in that report that DFR submitted. I suspect that because of the pandemic, other states have done what Vermont did in terms of, coverage and reimbursement during the pandemic. I'm not positive on that, but I wouldn't be surprised if that's the case. I'm not aware of any situations where a state has done anything relative to this issue post-pandemic, but again, I'm not positive, and that may well be addressed in the report, and perhaps Sarah knows better than I do.
One of the places where we're an outlier is the coding. Using in-person codes for telephone calls is an anomaly, and we feel like we should stick with the standard coding that is used across the country to identify which is phone calls. So even if you chose to, if you chose to keep the payment level the same, we should be coding it so we know what we're doing.
Okay, and Jen, you can correct me if I'm wrong, but I believe that Medicare has allowed for audio only through Medicare. Is that, am I reading something else, or?
I believe that is or maybe was true, and there had been some change. I think you heard testimony, or somebody's heard testimony from DIVA about what Medicare has done, because Medicaid used some of Medicare's codes for their purposes, but I don't know that I can speak directly to what Medicare has done.
We probably don't need to get into that at this point, but there's Sarah Teachout. Go ahead.
The one thing I'll say is that we all participated in the calls when we were developing the emergency regulations with DFR, and we really worked together to try and align our policies to make it easy for providers in this emergency situation. So, DIVA was trying as much as possible to align with what everyone else was doing.
Thank you. And of course, one of our concern also lies with the patient and ensuring that patient access is there. And given the extensive telephone network that we have in the state, that was facetious, I'm sorry, but as our telephone network improves, then it might be helpful, instead of driving 50 miles to have a telephone conference. So we'll have to sort this all out. Senator Hardy.
Yeah, I have a question for Chuck. In looking at your language that you're proposing, you say that consider the cost of such impact of such services on health insurance premiums and patients' out-of-pocket costs, and then the clinical value. What about the cost to providers? Do you think that should be a consideration or not?
Yes, Senator, I do think, and I hope I've accommodated that in the sort of the last phrase in my bolded languages, providers' costs in providing such services.
Oh, I'm sorry. Yeah, I was just looking at the previous language, your list above, and didn't see it. So, okay, thank you.
And that may well be a two-way street. In other words, if it's lower cost for the provider to do it, then that should be taken into account. Perhaps it's a higher cost in certain scenarios. I mean, I can see, audio only, I mean, I don't know enough to see all the variables there, but I could see that there could be a lot of just sort of different contexts in situations that would mean that a one size fits all reimbursement rule is inappropriate.
Yeah. And then thank you. And in terms of the coding, I don't know if this is a question for you, Chuck, or for Sarah. Sarah seems to be the coding expert.
I'm not.
Well, you play one on Zoom. I'm assuming there are different codes for non-audio only, so telemedicine that's not audio only, so via Zoom or
Audio, visual, yeah.
whatever.
I assume so, Senator. I am not an expert on coding.
Okay.
This is what I've been told when I asked our coding people, that there's an in-person code or a code for the service, like an evaluation and management visit. And then there's a telehealth modifier. And that's what we're using currently. So telehealth in this situation means either a telephone call or an audio visual visit.
Okay.
What we would like to use now are telephone specific codes once we get beyond the pandemic, so we can tell the difference between an audio visual telehealth visit and just a telephone call.
Okay. So it could be the
And
same.
now you've reached the limits of my CPT
No, you're
knowledge.
doing great. You're doing great. So that would be this, if there's a 20-minute visit in person, a 20-minute visit via telehealth that's got audio visual, and then a 20-minute visit via phone, they would all have maybe a code and a subcode or something like that. So you could tell how they were delivered. Okay. That's what you would like.
That's what we would like.
Okay. Thank you. And you too,
Okay.
Chuck, I'm assuming.
Yeah, so yeah, I know, and within that, there's other nuance. So we'll move on. Any other questions for our two insurance experts? Okay, so Helen Laban is here. She contacted us late, so she's not on the agenda, but she's an important part of the conversation around telehealth generally and audio only as well. So Helen, welcome. Why don't you introduce yourself for the record? And we also have something from you on our webpage, I think.
Yes, thank you, Senator Lyons. I'm Helen Laban. I am the Vermont Public Policy Director for Bi-State Primary Care Association. What you received from me was a one-page cheat sheet on the DFR proposals and how it tracks with the current telehealth rules, both prior to the pandemic and during the pandemic. And then also I sent, and this is what I'll try and show you on the screen, and I'm going to, we discussed, I'm not going to do full testimony here. I'm just going to do a quick introduction to the concepts. And I attempted to simplify audio-only telehealth reimbursement into one picture with 4 quadrants. Let me see if I can share that. Oh, it's disabled. I'm unable to share that.
Nellie, can you co-host Helen Laban, please? Nellie? She stepped away for a minute. I should be able to do that.
I can put up the image if that's helpful.
Or someone else
Okay,
can put it
go
up if
right.
it's on there.
Go right ahead.
Or I could just describe it. It's simple.
No, I like the picture.
Put it
Picture's
over
worth
here.
1,000 words.
She's a co-host now. She should be able to.
Oh, okay.
Oh, Nellie, thank you.
Is it sharing?
Yes.
All right. So I tried to make this as simple as possible, how audio only telehealth works. And we discussed some of these issues here. So there's telemedicine, and that's that part where it's directly replacing an office visit. And this is where the parity lives. And it was also an extremely high element during the pandemic due to extraordinary circumstances, right? And so this is a lot of what we are basing our conversation on, or have been basing our conversation on, that direct office visit replacement. And I should say, I expected patients to be really unhappy about this because they were being forced to access care in a way that they didn't want to because of a pandemic in many cases. But in fact, Todd Young at the UVM Health Network has great data and did a lot of work on patient satisfaction, and it was quite high. It was shockingly to me high how satisfied patients were with the telephone option in particular. We would expect to see this go way down after the pandemic. Your clinical decision-making changes when you no longer have the fear of COVID-19 and that keeping patients from seeing the office, right? So you're going to see a significantly different utilization after the pandemic. Though I would say the small number of visits that will happen are that much more important, right? It's patients who have real barriers to accessing care, real barriers to the digital divide, in addition to places where it just makes complete clinical sense to do things over the telephone. So that's the telemedicine and where I think a lot of the payers conversation has happened. I think the more interesting part of audio-only telehealth is in other parts of this circle. So we get into the other telehealth services, and this you've also talked about. This would be, for example, triage calls are often cited in this. And when they're used in this way, what we're talking about here is not a scheduler, but someone who can make a clinical conversation with a patient to determine what the correct next step is for them, whether that's to come into the office, have a different kind of telehealth visit, not something that doesn't necessarily need treatment like a worried well type call, referral to a specialist, all the different things you could determine from a short clinical call. These are a great part of efficiency for the future in the workforce. We see many healthcare systems moving to implementing these as a standard thing, and they're paid on a separate fee schedule. You don't get charged as if you came into the office for that. And in fact, if you do come into the office afterwards, you don't get charged at all. And then we also have blended care, and that's combining in-person and virtual. Here we expect to see a lot of work around quality. So we have good clinical evidence that, for example, in managing chronic conditions, this is basically the way to go. You have a meeting with your doctor, you set up a treatment plan, you have regular check-ins over the phone on how that treatment plan is going. So diabetes would be a great example of how this is used. And then we have the non-clinical. And these are often called social determinants of health work. For some of it, we're looking at how to overcome transportation, how to get over digital divide barriers, often not compensated work. And we really don't want to disincentivize this work. And this is one of our big concerns with paying less for a phone call, is that often that phone call is in the context of dealing with all these other issues, again, setting aside the pandemic. And we don't want to basically incentivize providers to treat those calls as lesser. We want them to spend more time with the patient. We want them to work with the patient on what their best and most appropriate treatment is. So this is how we're on the provider side thinking about audio-only telehealth. And it's fairly sophisticated to implement, but it's not out of reach. I'm not going to tell you this is how it rolled out overnight when we had 24 hours to shift to all virtual, right? That is definitely not what that resulted in, but it's where we want to get with this. And that's why the recommendation of the DFR working group was to essentially buy ourselves more time, to give some stability, to keep in place what's currently in the emergency rules, while we all work together to develop a reimbursement system that works through this type of sort of sophisticated, sustainable use of telehealth to provide better care to Vermonters, but also give the practices then time to implement it so that we don't have this pendulum of this changes and then a month later that changes and then Congress acts and the federal changes. We really want to bring stability and a reasonable deliberative growth process to how we use virtual tools in Vermont. And I will stop my screen share. So that's the summary of what we're looking at. And we feel that it's important to allow practices to use these tools, to be comfortable with these tools, and to help the providers who are working with their patients to deliver the best clinical care they can and remove those barriers to access, and also find a workable, high quality treatment plan that works for their patients and their life circumstances.
I was muted. Thank you very much. So I'm looking at your summary of the telehealth reimbursement policy, December 2020.
Mhm.
Is this the result of the working group work?
So on that handout, the left-hand side is what's currently in place and what we set up prior to the pandemic and entering the pandemic. And then on the right-hand side is the recommendations from that DFR working group. So it combines both current state and recommended state in one handout there.
Okay, all right, this is helpful. We won't go through it today, and I think that each of us should go through it and read it so we can understand what is being debated. I guess my question for you, and we've heard from the insurance companies that their position is that additional work should be done through DFR and rulemaking. And I know that there's a whole group that was working on this. So when I ask you, I'm kind of asking your perspective on that, the rest of the group, the clinical providers and so on. Do you believe that do you believe that that's the way to go, the DFR rulemaking, or is there an additional working group that's needed, or can some of these decisions be made as we're putting together our flexibility bill? I'll give you those three choices.
Sure. So we fully support the DFR working group. A lot of great work went into it. And I know you'll hear from Sebastian later, and he did a great job. So we fully support those recommendations. I think part of where we differ with the payers is what the steady state should be while we work towards a full implementation of telehealth across Vermont, and also how long that's going to take. So, So we would like to lock in the emergency rules through this waiver process through the end of 2024 to give us that much more time. And it will take a long time. I mean, if you look at New York State, which is investing a great deal in this process, they're using Google CEO money to stand up a full-time team to make this happen for New York State. We don't have that in Vermont. We got to buy ourselves some time here to make this possible for us and for our providers.
Okay, well, you just struck a chord with me. And it may be that we should be looking at guidance regarding new federal funding, and if something is available to fund something like this. So I'm going to ask my committee to keep that in mind as we look at guidance around federal funding that was passed in December, but also any new money that might be appearing in the next next month or so. So that, I think, it is expensive to do this, not just in time, but also in resources. We understand that. So we don't want to make it, once we have an opportunity to do this, I think it's really important to do it right. So questions, Senator Hardy?
Yeah, I guess to that point, Helen, what specific, I'm looking at your recommendations that you provided, 7 recommendations. What specifically are the costs that make this so expensive? If we've been doing it during the pandemic, what are the additional costs that you're thinking are necessary to continue to do it, or to do it right, or to do it better?
I think we're using costs maybe a little bit differently. So some of the costs shouldn't be borne on the back of payers, right? It's not Blue Cross Blue Shield's responsibility to resolve the digital divide in Vermont. They're not going to be building out broadband. So, some of the costs are separate from what we're talking about here, which is just the reimbursement schedule for telehealth. The primary costs to the practice are going to be, again, not well correlated with the fee schedule in some ways, because it's things like building new workflows, doing new trainings, reinventing how you do your team care. So those are practice transformation costs. And then additionally, in the actual service provision costs, most of the extra costs that we would see in that would be things like when we are delivering those non-clinical services, working with a patient who can't get online, but wants to get online, or can't get transportation, is trying to find a way to come in. So that's where the kind of in the service moment costs come in with our providers.
Okay, it seems like a lot of those are already happening. I mean, doctors' offices are already helping patients do all those things and are already have workflows that involve using the telephone to provide services in some way. So I'm trying, and the digital divide, you know, Senator Cummings and I are working on that in our other committee. So I'm just trying to figure out what specifically is new costs.
Right, Senator Hardy, you're exactly correct. What we're arguing is that the payers want us to be reimbursed less, and we're saying, no, we're fully working up to the cap of these costs. We should keep parity reimbursement for the in-office equivalents and the full fee options for the non-in-office equivalents. So correct, we believe in the way it's currently set up is what we want to lock in for the next couple of years.
I see, okay.
And just to add a little bit, the Provider Stabilization Fund is providing funding for a lot of this during the pandemic. So there are additional resources that have been put into the system to support the businesses, the healthcare businesses. Some of them would fold without the full payment for audio, visual, and audio right now. So it gets to be during the pandemic, we've seen some difficult times for folks. And so this is an opportunity to fix a system and to plug the gaps, I think, so that going forward, we don't see the fragility that we might have seen previously. So it isn't simple. Any other questions, committee? Senator Hooker.
Thank you, Senator. I'm curious to know about the effect of these changes or the permanency of this funding on premiums, and what would that do to the consumer's costs? And has it been, well, it probably hasn't, because this has only been a so far 10-month deal, but what kind of effect is this going to have on insurance premiums?
So Senator Hooker, if I may, I can speak to the change in costs. I do not calculate insurance premiums, so I cannot speak to that. I would say I wouldn't necessarily take what happened during a pandemic as typical utilization patterns. When we look broadly at the costs of audio only parity, a lot of it is going to be a wash overall, but a savings to the consumer. So those telemedicine visits that are replacing what would have happened anyway, the consumer saves on transportation, childcare, time off work, but to the payer, it's the same. We are seeing right now that no-show rates have plummeted. So people who are just either not showing up for their appointments or dropping out of treatment, that's gone dramatically down, in some cases to near zero, especially in mental health. So in that sense, there's more cost because people are actually accessing the care to which they are entitled. And additionally, coming out of the pandemic, I'm sure you've heard, we're anticipating significant increase in the volume of some services, particularly mental health, as well as deferred care coming through. And we need some way to accommodate that organic increase in volume. So you're going to see that, and in that audio only makes access easier. You're going to see more of that. That is an additional cost. Long term, we would anticipate there being savings because we can use resources more efficiently. People get their primary and preventive care. They don't need to see specialists. So in the long term, you would see that begin to equilibrate, we would anticipate.
Senator Cummings.
Okay. The proposal is that we maintain the status quo, at least for some time, in which a telephone call to my doctor is reimbursed at the same rate as if I go in, get my blood pressure checked, have a hands-on visit, get my weight checked, and everything else. I've got a concern about the cost. There's been money going in here, and I've got a concern about equity. Lower income people traditionally have more trouble with transportation, with access to broadband. So they're going to be required, perhaps, more often to settle for a phone call and call up and say, I've got a headache. Well, no one's checking my blood pressure. I have
Therein lies a conundrum. Helen, did you want to comment?
Sure. I think that is somewhat an artifact, though, of our pandemic experience with audio-only telehealth. The providers are not going to default to that when they don't have the constraint of COVID-19 on them. So you would find that, and we heard this again and again in the testimony, clinically speaking, except for those instances where it clearly is the best choice. I talked about the chronic care management and some of the MAT treatments, but generally speaking, for that in-office replacement, it's the last choice of clinicians. When they're offering that, it's because they really need to offer that. The patient wants that. The patient truly can't get in. They need to have an engagement with the patient. I will concede that is not what we saw during the pandemic, right? People were not rushing in April to bring people in for wellness visits. So I think we have a very distorted view of how audio only will be used moving forward.
I can see where in mental health visits, which is generally I speak, you speak, we listen, we talk. It's a different form of treatment than having somebody look in your eyes and take your blood pressure. I can see where that may be the same level of treatment. But I have a problem when we talk about working over transportation hurdles, getting paid at the same rate as sitting on that examining table. It just seems that there is a different level of care possible. Telehealth, you can at least look at me and get some idea if I've put on 100 pounds sitting at home during the pandemic.
On Zoom.
On Zoom, yes. See my eye strain. I think it should be reimbursed. I think maybe mental health could be reimbursed at the same level, but to just do a blanket, all telephone audio only is going to be reimbursed at the same rate. I'm not comfortable with that.
And for a point of clarification, if I may, we're not saying that all audio only, all telephone calls be reimbursed at the same rate. So like those non-clinical services, for example, we're not saying that gets reimbursed like a doctor's visit. We're saying that only when in the clinical determination of the doctor working with the patient, so when both the doctor determines it is equivalent and also the patient has requested and elected into audio only, that is the only scenario in which we're saying there should be parity reimbursement. It's a very thin slice of the pie there.
There's a lot that needs to be further debated on this, and so Senator Cummings and I will have to have a discussion about whether or not mental health services should be audio only. I could see the need for looking at the patient body language and eye contact, and
I would do that audio video. I think would be the best way. I can see a crisis.
I just have one more question and then we probably should move on. The question is that you have put down the summary of the working group recommendations. Were these recommendations agreed upon by everyone in the working group? Was there a subgroup that disagreed with it?
Senator Lyons, to be honest, I thought that we had all agreed. The providers compromised a great deal from our starting position. It was a surprise to us when it was not taken as consensus recommendations.
Okay. Yeah, that's always a problem. I know. And once people move away from a working group, and get back to the home base, they might change their minds. That's true for everyone. So, committee, and for Helen, thank you so much for making yourself available on short notice. We appreciate it as well. Chuck and Sarah, we also appreciate your participation. As I said before, the House is taking a bit of a lead on this. It doesn't mean that we won't come back to it in more depth, but we certainly need to understand any language that's proposed to us. So we'll keep working on it a little bit. We also don't want it to hold up the rest of the bill. So that's another critical piece. All right. So we're going to move on to a different section of the bill, and we'll say thank you to you guys. You can welcome to listen in. We're fine with that. And David Hurley is here. Jen, can you tell us, as David begins his testimony, which section or sections of the flexibility bill we should be looking at?
I think it might make sense to just hear from David, because I think some of his issues are maybe broader than one or two sections, or he may want to focus you in on particular ones, but I'd rather defer to him to make those decisions.
Terrific. Okay. And David, welcome to our committee. This is the first time you've been here this year. So I'm going to do a quick around the block introduction to the folks that you see on the screen. Senator Josh Terenzini from Rutland.
Morning.
Senator Cheryl Hooker from Rutland. Senator Ann Cummings, Washington County, and Senator Ruth Hardy, Addison County. So welcome. And why don't you give us a brief introduce yourself for the record, and then give us a brief update on the testimony that you've got.
Sure. For the record, I'm David Hurley. I'm the Executive Director of the Board of Medical Practice. I also do the licensing of hospitals and ambulatory surgical centers. And I was contacted by Jen because the board has been involved in the discussions having to do with the emergency authorities for practice in the state of Vermont. And so just had a couple of things to add to the conversation. One is with regard to the time extension. And there have been different dates kicked around. And, I think when we originally started, we were talking about the duration of the emergency, and then that was changed to plus 90 days after the end of emergency at some point. And then last fall, in anticipation of a difficult winter and your absence until January, we pushed that out to March 31st of this year. And that brings us to where we are now, of looking at, with the continuing environment of challenges with the pandemic, how far out should we push the date at this point? And I know that I've heard that there was discussion the other day, and OPR weighed in on this and suggested pushing it out for a full year to March 31st of 2022. And I couldn't be here then. We were having our monthly board meeting, and I brought it up and discussed it with my members. And, they all voted on a couple different motions to try and clarify what their position is. They definitely do support going 90 days beyond the end of a state of emergency. That seems to be a reasonable balance between, the risks of allowing unlicensed practice of in some instances with the telemedicine, people we don't even know who is practicing here from other jurisdictions. That's balanced against the risk that there may be some friction points of people having to find new sources of care if they've come to depend on people who are taking advantage of those special licensing or non-licensing provisions. And also, what an important piece of this is that there are a lot of Vermonters who are being cared for by systems across the borders, especially Dartmouth Hitchcock is providing a lot of their routine care with telehealth visits instead of Vermonters driving over there to get their care. And they've been to a good degree relying on these special provisions to avoid having to get all their providers who are doing that licensed. Though that many of them have for years, they've been having more and more of their providers obtain Vermont licenses as well as New Hampshire licenses. So, as I said, that the board thought that was a good balance of the risks of having that 90-day date to patient access and challenges for the providers at Dartmouth to get licensed if they want to continue practicing more than 90 days after the end of the state of emergency. I heard that the date proposed and that is being considered is March of 2022. And my members did not support that date. And I would characterize the comments that I heard. It just seems like, we don't have enough information right now to justify telling the world that we're going out for another full 14 months without a requirement to be justified to practice medicine in Vermont from anywhere doing telemedicine. That, the risks of, we don't even know at this point how many people are practicing telemedicine here. And, it's too soon to be aware of what the problems may be that have come up. And we've worked for years trying to, get a handle on the opioid epidemic, and physicians are trying to be more careful in their prescribing of opioids. And this is just one example of where there may be some bad outcomes, but in allowing people who aren't licensed here and who we don't know are practicing here to practice in the state. And so when a Vermont provider is trying to reduce the opioid prescriptions for one of their patients, or cuts them off because of signs that they're diverting the drugs, it may be easier for people to find someone who's looking to profit and write prescriptions without a good basis. And that's just one example of the kinds of risks that we have allowing people to practice here without being licensed. And 14 months is a long time.
Okay,
That's
so
all.
yeah, I mean, it clearly depends on, obviously, when the emergency ends. We're all optimistic once the vaccine is distributed across the country. I do have a comment and then a question for you, and that is that as the pandemic started and we extended telemedicine to folks across state lines, I had a number of contacts from providers and patients about accessibility, and docs not knowing whether or not they could practice medicine through audiovisual from New York for patients who ordinarily would drive across the border, or Massachusetts and New Hampshire. So how are you going, with all of that in mind? They just didn't know. I mean, they didn't know that they could continue to care for their patients. How will the board notify physicians or patients? How will the notification go out so that folks know when the 90-day period is up? I mean, knowing when the emergency ends is one thing, and then having a date certain 90 days later is another. How will that notification happen?
Again, that's, that's one of the rubs. When this was originally conceived, all the emergency authorities, I think the board maybe was a little bit more conservative than some others, but we didn't object to this idea of deeming for telemedicine and just throwing the doors wide open. It was a time when, New York had gurneys lined up in the hallways, all their New York City metropolitan area hospitals, and we're just overwhelmed with patients, and they threw the doors open basically and said, anybody want to come practice here, please do. We'll post it on our website. We will let the hospitals who we know have catchment areas that include Vermont populations. We'll let them know probably that it's ending. Otherwise, it's incumbent on those providers to stay aware if they've started practicing in Vermont. I would hope that they know they need to. They found out that the door was open and they could come and practice here, and hopefully they're responsible enough to try and be aware of when the door closes.
That sounds like a plan. The hospitals and the website, I would hope that maybe some of the professional organizations could help out, but I just don't want it to be that I get another set of 2,433 emails from patients and docs saying, I've heard I can't practice here anymore, and what's the real story? And then I have to go back and look at the end of the emergency and the end of the 90-day period. So,
Well,
yeah.
You raise a good point, Senator Lyons, is we can also engage the patients, and we can try and, get some press releases out there and let patients know that if you're receiving care, you may want to make sure your provider knows that this is coming to an end if they're not licensed in Vermont.
So you wouldn't be averse to our putting something in that says that the Board of Medical Practice will provide notice as extensively as possible to inform patients and providers about this timeline we're talking about?
I guess I'd be good with it as practicable, maybe.
as practicable.
Possible.
I love that. Yeah. Okay. All right.
Yeah, and we can, I think we can put out notice to the other, we can ask our other boards in neighboring states where, probably a lot of this is taking place. And that, those are the ones that we're really concerned about, is the cross-border relationships that we are trying to support and sustain with these authorities are probably the most critical.
All right, thank you. We have two questions, one from Senator Hardy and one from Senator Hooker. So,
thank you, Madam Chair. David, thanks for your testimony. What we'd heard from others was that a date certain would make it easier to do, because they could say, we know it's going to be March 31st, 2022, or whenever we decide, rather than the 90 days, because then it becomes a little squishy if Vermont's ends its declaration of emergency at a different time than New Hampshire or New York or whatever. And, it just becomes more confusing. So I'm wondering your thoughts on that. And then the second thing is, I appreciate your concerns about the potential of, bad actors or whatever, however you phrased it, maybe practicing in a way that wouldn't be up to Vermont standards or in a dangerous way. But have you been aware of that? Have you had any complaints? Have you had any issues with that at this point since the start of the pandemic?
I can't say we've had a rush of complaints that are associated with it, though. I think, in a lot of instances, it takes time to become aware of these issues. For one, like the one, with the opioids, the patients are almost never the ones who are, they're not going to let us know. We're not going to get a complaint from the patient who's getting the prescription that their regular provider wouldn't give them. So yeah, again, I can't say that I've seen a rush. I have seen evidence across the country of a lot of people profiteering and taking advantage, a lot of unprofessional and probably criminal activity associated with the pandemic. I get every day I have news sent to me by national organizations about cases. Like there was, I think it was an APRN or maybe a PA in the Midwest who had made hundreds of thousands of dollars selling amniotic fluid as a stem cell cure or preventative for COVID-19. And again, having a licensing requirement, does that necessarily stop people who have a criminal bent? Probably not, but it's just it just facilitates people who want to do business and take advantage of Vermonters to take away the licensing requirement.
All right, thank you.
So, and again, on the date, clearly my entire board supported 90 days, and the vote of the members who voted on the March 31st, 2022, it was 9-5, 9 against supporting that and 5 in favor. So, it's not life and death, but we just felt like, the other thing is when you tell the world, and again, unfortunately, I see too often the stories about people who look at medicine not as a profession, but as a money-making opportunity. You tell them that this is going to be for 14 more months, it's going to be that, and it's like, oh, that's another place we can go set up shop. But again, it's not, I can see the advantages of having 2022 be the date, March 31st, 2022, I guess is what I'm trying to say.
Well, I mean, having the board's position is very important to us. And so we appreciate that you have taken the time for the board to discuss and then vote on this. That is extremely helpful.
So there's one other thing that I wanted to touch on.
Before you move on and then yes, no? Okay, we're all set, Senator Hooker?
I'll wait, yeah.
Okay, good.
Oh, I'm sorry.
Yep, no, go right ahead.
So the other thing is really, hopefully a very small point. There's a couple places in Act 140 where when we crafted these originally, we had we said that for people who were going, and I don't want to make it too confusing, so I'm just going to talk about them as a whole. There's different categories. There's people being deemed from other states to come in and practice. And when they're in Vermont, we had limited that to practice at a licensed facility. And just with the idea that the hospitals would, be another layer of protection if these people were really needed to support care for people affected by COVID. It's probably going to be in the hospital setting. And there's also that phrase was used also with regard to inactive, or the terminology used was retired, which isn't really a good term to use. It's really, are they active or not active? And that's being changed in some places, I believe. But so that in a licensed facility was used with regard to our ability to re-license people who had stopped practicing. And that was limited in some ways to licensed facilities as well. I had suggested adding a couple of categories to that. One is the Medical Reserve Corps. And this is important because we have a lot of people looking to come back and support the vaccination efforts, which are being coordinated now. Medical Reserve Corps is an important part of that. And so we have a lot of retired physicians wanting to do that. And so I'd like to add MRC. And then I also thought if we added in FQHCs, and that makes sense to me because they, like hospitals, have, organized medical staffs, and it's a way of expanding the reach of these authorities to make them more helpful without adding much, if any, risk.
Good, thank you. That's very helpful. Questions committee. Cheryl, did you want to follow up with your question?
Well, the other day I had asked about why telemedicine providers from other states weren't registered. And it seems to me that just to have a registry of them, not a licensing per se, but a registry so that we would know who they were. Mr. Hurley, you've talked about not knowing who these people are even. And I think that Lauren mentioned a really large number of these providers that are that may be active in the state. So I didn't know if a registry would help in that regard. It certainly would help in notifying people when the when the emergency finished, and giving them the date that it finished and how many days they had after that, if that's the route that we go.
I think that, I think from the beginning, I would have been a lot happier if there was a requirement for either, registry is a little bit of a formal, and for me, the problem with registry was if we were going to, that to be able to do it right away, and if that would require modifications to our IT system, that would have been a challenge perhaps, but at least provide us notice, fax us, email us, get us, be able to create a list of who it is. Exactly. The concerns you have are my concerns. How do we even communicate with these people? How do we make sure that they've been provided copies of our requirements for opioid prescribing, for using the our prescription monitoring system, for the practice rules?
Good, thank you. That I think that was helpful, and it may be that we have something in there in the bill regarding notice, in both directions, and Senator Hooker has been thinking about this for a while, so it's very helpful.
Yeah, well, I really appreciate you bringing that up, Senator.
Yeah. Okay. Any other questions for David Hurley? We're good.
Hey, well, thank you, everybody, and nice to meet all the senators who I hadn't worked with before.
Good to see you. Take care.
You too. Bye.
All right. So, Jen, I think what we'll do, we've got a little over an hour left. Let's spend a little bit of time on the flexibility bill. Maybe you could help us understand what we have just heard, in particular from the Board of Medical Practice. And then I think the audio only is going to be an open question until we hear from our House counterparts a little bit. So why don't we do that? Why don't we pull that bill up, and then you can help us.
Sure. Do you want me to put it up on the screen then?
Sure.
Okay.
And let's set a time for this. Why don't we set until about nothing like being specific, right? About 10:45, 10:50, and then because I'd like Katie to come in and talk about S42. So let's do 10:45, and I don't know that we're going to we might get a stretch break in there. Let's see.
That's great. And I'm keeping an eye on the House floor as well, because when they get off the floor, the House Healthcare Committee is returning to the audio only telephone language that we've been working on in that committee.
All right.
So I have a new draft for you today. I made the changes that we talked about yesterday and tried to highlight in yellow where I've made changes kind of since what we looked at yesterday. So the first part was just adding the advanced directive piece and the immunization registry language to the statement of purpose. So keep going through here. So there was something that you got an email about, or at least the chair did yesterday, from some of the providers around the provider enrollment and credentialing language that they're, I think, preferring a date certain. This hadn't been in here necessarily to have a date certain, but getting rid of the language talking about the last to terminate of the various state and federal emergencies, and instead going with a date certain. So I've kind of put a placeholder in for that piece with the possibility of a date certain. And then I think we would get rid of the it turns back on if there's another state of emergency language, because we would have decoupled it from the states of emergency. So that's just something I think for you to know is in there, and that I will address more once you have made decisions around timing. The pieces that you just heard about from David Herlihy are start here in section 17, which is OPR and the Board of Medical Practice and the out-of-state healthcare professionals. So again, this is going to be the question for you about whether you want to allow somebody who is licensed in another US jurisdiction to be deemed licensed here until a date certain, or during a state of emergency plus some time after. But I think he is interested in adding not only telehealth. Oh, I see a hand waving, so I will.
Senator Cummings, go ahead. I can't see everybody, so but
Okay.
go ahead.
We're going through this. We made these decisions about a year ago when, as David Herlihy said, New York City had gurneys lined up in the halls. We were setting up, overflow emergency hospitals, and it was seen as a crisis that we needed to get folks in for. My question is, did we do it?
What do you mean, did we do it?
Well, did hospitals in fact take on a whole bunch of retired physicians or bring people in? Did the need arise to use the things that we did, which might tell us something about the necessity to continue it? Because there is a risk here to quality.
I think there are two things there. One, what we heard from the providers the other day is that, yes, they'd like to extend the use of the retired folks. And we just heard from the board that they will be helpful during the vaccination process. Then the other thing is on the telehealth, and that which is a separate issue, which is allowing people.
I wasn't talking about telehealth.
Okay. All right. Got it.
I was talking about, did hospitals bring in a whole lot of folks who were licensed in Hawaii to work in Vermont? Did we bring in a whole lot of professionals who weren't licensed in Vermont? I'm just looking at what happened after we did this.
Okay, why don't we reach out to our little coalition and we'll ask that question specifically. But it was my understanding that their request for extension was based on their experience. So we'll validate that.
Just like to, I'd like to get a number.
Okay, so the question is, did retired or out-of-state practitioners come in and help our state? That's the question.
Yeah.
Okay.
And I think you may be able to get some of that information from the Board of Medical Practice and OPR as well, because those pieces that required the person, where the person was going to be working on the staff of a licensed facility for the out-of-staters, they had to provide information to Board of Medical Practice or OPR, and for the retirees, they had to provide information as well. So they may be able to give you some numbers as far as who
Jen, would you have time to reach out to those two?
I can send them something.
Okay, sure. I think that's good.
And I'm sorry, Senator Hardy, I think you had a question or comment.
Yeah, I was just gonna say, I mean, section 17 kind of blends the two issues in the language, because it does also include telehealth in it. And we did hear definitively that a lot of people took advantage of the telehealth thing, and but they're not sure the numbers because
I don't know.
there was no list like Senator Hooker has mentioned several times. So but it does sound like, Jen, you think they might have the numbers for the people who were actually working at a hospital.
Well, for the people who were actually working at a hospital, they had to provide information. They had to provide their name, contact information, and the location or locations where they would be practicing.
Okay.
To Board of Medical Practice or OPR, depending on the profession.
And I do know that there were lots of people who signed up for the medical corps, the MRC or whatever it's called. And I think we got testimony yesterday or one of these days that were like hundreds of people signed up for that. So that would probably include some people from out of state and retirees and stuff too.
Yes, exactly. And I think that's the request, to extend that. So.
Right. So right now the language only addresses, and this is a good sort of segue into the language and what David Hurley was mentioning. So right now the language talks about providing telehealth or being part of the staff of a licensed facility. And I think the request is also to include in here or to work as a member of the Medical Reserve Corps or to deliver services through an FQHC. His point, which was a good point I hadn't thought about, is that Vermont doesn't license FQHCs because they are federally regulated, so they don't actually fit within this licensed facility language that we have in here. So I think some of the questions for you are whether you want to put them, sounds like I'm hearing some interest in including those provisions around the Medical Reserve Corps and the FQHC, whether you want to also include, also apply this notification requirement to out-of-state providers using telehealth, the point Senator Hooker brought up and that you were discussing with David Hurley, that has not been a requirement.
So I guess the question is how to say that. I mean, obviously notice has to be given, and his suggestion was a website. There are two things. One, the notice that there's a 90-day after emergency extension, so that through the hospitals and the website. And I think we would want to make it further, additional notices through press releases or whatever, PSAs, I don't know.
Right, I think that piece is going to depend on what decisions you make around timing. So if you decide to go to, I mean, you may still want notice pushed out from the regulators, whether it's 90 days or 3 months after the end of the state of emergency or a date certain.
Regardless, I think for this group, because they aren't registered, licensed, and there's no list of who they are, I think there somehow is going to have to be some communication for them. And then Senator Hooker's idea, which is to have some kind of notice or information from practitioners whenever they practice across the border. That's a whole nother issue.
Right. So, I mean, I think you could probably put the telehealth piece right in with what you have now around the requirement to provide name and contact information, at least for somebody who plans to provide healthcare services in Vermont as part of the staff of a licensed facility. So right now you have out-of-state providers. If they're going to do telehealth, they don't have to do anything else. If they're going to work as part of a facility, they have to notify the Board of Medical Practice or OPR. For the retirees or inactive or whatever you want to call that group, you require them to provide notice to OPR or the Board of Medical Practice for telehealth and to work in the staff of a licensed facility. So
Okay.
you could make it consistent in both pieces if that was your
I think that makes
What,
sense.
what do you think about that? Does that solve your problem, Senator Hooker?
I think it helps. It certainly helps. And I think it would give some solace to Mr. Hurley's group, because their concern was bad actors, and at least we'd have names. If we see that their names are coming up someplace else.
We
then-
don't want those COVID cures with stem cells coming in.
Exactly.
Yeah, we get that.
Exactly.
We have
So in
another
this-
bill for that.
Yeah.
This also makes it easier then for the Board of Medical Practice and OPR to notify everyone who has informed them and provided contact information that they're providing telehealth about when that authorization ends.
Whether it's 90 days after or a date certain.
Regardless of what it is, to be able
Yeah.
to provide them notice that this is ending or this is time limited.
Yes.
Sure.
Yeah. Okay. Okay. So we're good with that?
Yeah.
Terrific.
Okay.
What's
so just
next, Jen?
Providing.
Well, you
I'm
write
just
that
making a
down.
note to
Yes.
myself for the things that I have to add for you to look at next time. So then there's that same piece around retired healthcare professionals. I had not heard concern about the terminology, although I can understand whether somebody considers themselves retired versus inactive. Maybe people may have different perceptions that affect whether they think they fall into this category or not. So we can certainly look at changing that language from retired to inactive. Or something like that. I can ask the Board of Medical Practice and OPR for their preference on language. Does that make sense to the committee to pursue?
Yeah, I think clarity always makes sense.
Yeah. And particularly it comes from the board. So,
Yeah.
I kind of fits.
Okay, so I will check in with them on that.
Can
And
I
then-
just go back to that before we get off from that?
No.
Retired, sorry.
I wish we were
Retired-
sitting around the table, Senator. I'm sorry.
I
It's hard
know, I
to do.
know.
Okay, go ahead.
And I can't see you, I can only see the speaker. So retired and inactive, if someone lets their license lapse, as opposed to having a license and just not practicing. I'm just trying to get a clarification. Would that then assume that the lapsed license is retired?
These are good questions. I think it depends. This would be something I'd want to ask David and Lauren about. So you're saying if somebody's let it lapse rather than sort of opted to go into inactive status, is there
Right,
a
and-
difference there? And is there a reason to treat those differently? I think it's a good question. I do think in either case, it is helpful to move away from that retired language. For example, I have an inactive license to practice law in Massachusetts, but I don't consider myself retired. I just have an inactive license in that state. So, so that may be helpful.
And don't consider making it active. Okay, so Senator Cummings has a
Stay
question.
right there.
Oh, I got a couple. Right, I like the registry for telemedicine. I especially like it because it might facilitate second opinions. But at this point, if you send somebody's records to Dana-Farber for a second opinion on a cancer treatment in Boston, does the doctor at Dana, I don't want that doctor to have to be licensed in Vermont in order to do that. And telemedicine, and that's store and send too.
Store and forward, yeah.
Store and forward, yeah.
Store and forward. Being able to do that kind of thing on telemedicine would definitely be an advantage to people who don't necessarily have the transportation or the money or even the physical stamina to haul their body to Boston. Driving in Boston can give people in Vermont heart attacks. It's another world.
You get lost.
Yes, you do. even those of us who used to know how to drive there, they changed the one-way streets every 6 months. But I like that. On the other hand, I remember taking tons of testimony on physician shopping for opioids when we set up the registry,
Yeah.
all the stories about the pill doctor factories. And I think we need to know who's writing prescriptions and for what in Vermont, because now all the anecdotal evidence we have is that substance abuse is up. People are shut in, they're losing their support structures. So I like Cheryl's, at least a registry that
So
we
the
check on occasionally to make sure it's still active.
Yeah, the question about a registry though, remember, and what we heard from David Herlihy is that's a pretty big deal in terms of establishing
Well,
IT, but.
Yeah, no, I'm talking about a list.
Okay,
we
list.
should
List is
know.
good. We like a list.
Yeah, I'm not sure what's the difference between a list and, except maybe you can register yourself, but we should know who is writing prescriptions in the state of Vermont
But
and who is giving medical
I think
advice.
that's what you just added with the requirement that the people doing telehealth provide their name and contact information to the board. So,
And we should
if by
spot check it
registry
on occasion.
if by registry you mean some kind of, electronic system or something that the public can access, I think that might be different.
Yeah.
But as far as just the various boards knowing who's practicing in their professional regulatory area, I think that's the language that you just discussed adding. So it sounded like the committee was kind of had consensus on that.
Yeah, I think a registry, just based on my work last session with an OPR bill, is a much more
Heavy duty
thing. Heavy duty. They would need money. They would need all this stuff. And I think what Senator Hooker's talking about is just, fax a letter to the Board of Medical Practice saying I'm seeing patients in Vermont, or that sort of level, which is not expensive, but they would still know who the people are.
And we do have information about docs who might be prescribing Schedule 1 or 2. So we know.
Well,
Nobody prescribes Schedule 1.
I know. I
Those are
meant
not
2.
prescribed.
That's why I corrected it.
But if I'm in Arizona and I'm prescribing opioids to somebody, how does that work? Who's
so I think we're getting off on yeah, we are. I mean, we can come back to that question, and maybe we need a little review of how the prescription drug works, how prescribing works, and who keeps track of what. And then we also have a very strong detailing program in the state for docs, but it doesn't go out of state. You're right, Senator. But there are
anti-detailing.
Yeah, we got that. But we anti-detailers. But we also have we'll have to go back and get a review of how that all works.
And it may be useful to have, David Herlihy or someone come back in and talk about how it works for providers, the relationship between the Vermont prescription monitoring system and these deemed providers, because I don't know the extent to which they would know about or have access to report prescriptions to the Vermont prescription monitoring system.
Nothing is disconnected in this committee. We can go right on. So thank you, Senator Cummings. All right. So where are we, Jen? We got the list settled.
Yes. So let me put
and we got the Medical Reserve Corps
language back up.
and the inactive versus active. Did we
go.
decide that
Let me
would be
just-
better? That was. a
Yes, I
rec-
think you decided inactive is better.
But we
I
need to
think this
find
puts
out
our
what it
language back up.
means for people who have just let their license lapse versus those who are fully retired. Difference.
Right.
All right.
Yes, that's one of the questions I'm going to ask is,
Yeah.
yes, does that language work? And is there a difference between someone who's let their license lapse versus opting for an affirmative inactive status or retiring or something like that?
All righty.
All right, so then we get to, so that was the retired or inactive piece. I don't think you made other changes to that other than I will add the Medical Reserve Corps and FQHC language there as well. And then as far as the other changes, so I did make a little bit of a change here based on, so this is now, we're out of Act 91, we're into Act 140, because this is one of the pieces that was added specifically in Act 140, and these are some temporary provisions around the Board of Medical Practice and temporary licenses, and then
Right.
also specific in this subsection B to physician assistants. And really just trying to update the language a little bit to reflect the changes made last year to the physician assistant licensure and the fact that they are not, at least going forward, supervised, but rather they have a practice agreement. But it's my understanding from David Herlihy that there are some who are still, because their licenses are still under the old rules, they haven't had to renew their licenses yet based on their license cycle. There may be some who are still under that supervision. So I just moved the language a little bit in a way that worked for him and seems to cover both situations without specifically using the supervision language. So it still allows the executive director or the Board of Medical Practice to waive certain requirements for physician assistants, including scope of practice. I just moved scope of practice down, and the requirement for documentation of the relationship between the physician assistant and physician. So we thought that language was broad enough to capture both the supervision circumstances and also the practice agreement. So
That's good. Yeah.
It's more of a conforming to other changes in the law change, but I wanted to highlight it for you.
Thank you.
Then section 3 is that standalone piece that has the audio only in it.
Our favorite.
Yes, and so that has down here, DFR must consider adopting and have the authority to adopt rules expanding patients' access to and providers' reimbursement for healthcare services, including various types of services delivered remotely through telehealth, audio-only telephone, and brief telecommunication services. And so we do need to talk about, at a minimum, dates on this one too. I think when Helen Laban testified, she talked about it going through 2024. This would have it go through 2023 and end no later than January 1st, 2024. So we just need to make sure whatever choice you make, everybody is understanding what it means. So in this case, it would continue DFR's rulemaking authority in this area for audio only telephone through 2023. And it would end at midnight as it turned to January 1st, 2024. That's literally what that means.
That's all right.
And then we get into, and I took out the highlighting stuff. So we have the advanced directives and their remote witnesses that we looked at yesterday. The immunization registry. Oh, I did not remember. I will make myself a note to put in the rest of that, or at least some more of that immunization registry language to provide context.
Yes, that would be helpful.
More.
Good.
Yep.
All right. So we've got some things to think about. I think we'll wait. We're going to pick this up again. I think we have it scheduled for Tuesday, if I'm not.
I think that is correct.
Yeah.
Now for the next version, do you want to see it with a date certain in it instead? Or do you want to stick with some version of state of emergency plus a period of time. And I actually think, you know, we have 3 months in here, but I think when David Hurley, he was talking about it, he was saying 90 days, and 90 days is clearer than 3 months if you wanted to go that route, just because it allows everybody to calculate.
You're talking only about that one section, right?
No, I'm talking about any and all of it.
Okay. Well, I guess, and I'll let the committee state whether they agree with this or not, but I think given the request from so many to have a date certain, that we should go with that request, including OPR's request. But then Board of Medical Practice would like to have its own timeline. It's 90 days, but and then have them providing notice to folks. I think that.
So I think it may, I mean, you may want to hear from
Ain't too
OPR and the Board of Medical
confusing?
Practice again. What?
Is that too confusing?
Well, I think it may be confusing for providers and patients to have OPR licensees, which include osteopathic physicians, under one set of rules, and allopathic physicians under another set of rules. And most people don't know which one their doctor
PAs.
is.
Right.
Right.
and
So
PAs.
PAs would be under one set, but
Mm.
APRNs would be under another set. So I think it may make sense to at least consider aligning those, which may mean either hearing again from,
Well,
or asking the board and OPR to consult and try to agree on something.
so we might do that. I mean, we did hear that it was a 9 to 5 vote, and that it may not be a stretch to put a date certain. What are you thinking, Senator Hardy and Senator Hooker? You both have your hands up. ahead.
Based on the testimony we've seen, and I completely agree with Jen that I think consistency is better because it will just confuse patients and providers. I think a date certain makes sense because it's just easier to say, you know, March, whatever, 31st. You know, I don't know if March 31st is the right time. We still don't know what's happening with the pandemic. But I do think that, you know, providing some kind of guardrails, and I think part of it is, you know, Senator Hooker's notification provision. And if there are other things that the Board of Medical Practice would like to include that would be sort of guardrails to ensure that, you know, this doesn't get taken advantage of, I would be in favor of that. But I think across the board, having as much consistency and then the ability to tell people this is when it is, and there's no gray area would be helpful.
Anyone disagree with that? Sounds good to me too. So let's do that. And something else to think about. I do want to kind of move off of this bill and have Katie come in and talk about S42 for a bit, but also think about since we're going to the date certain, how or if and who might be providing notice to their constituents. When we've heard from a lot of different groups on this, nursing homes, visiting nurses, all different kinds of providers, hospitals, etc. So do we want to have that general, I'm not talking about the list now, I'm talking about the notice of what's happening. Just think about whether we want to have some general notice provision in there. And we don't need to make that decision right now, but it could, I'm thinking, unless Jen tells me differently, I think it probably could be pretty general for all the groups.
It depends
Depends
what you
on
want
what
it to
it
do.
is.
Exactly.
Exactly.
It depends on what it is.
So think about that, and we'll decide what and if we want it to do something and what it might be. If we have a date certain, maybe we just don't need it. And the value of March of 2022 is that there's time for the Senate session to be engaged and maybe a change to be made again next year. Okay. All right. Jen, thank you so much. It's been very
My
helpful.
pleasure. Great. And I will work on having a new draft for you to look at on Tuesday.
Terrific. Okay, so committee, we're going to we're going to, Katie has run down the stairs and down the hall to be with us on S42. So Katie, let's just go through what you have for the bill for us, and then we'll open up discussion. My goal today is to at least get to some consensus on the bill, and then we'll try to put a vote in place on this bill early in the week. I was thinking Tuesday. I'm not sure we're ready to do that today. I think we need time, and I always like to have a day between our last discussion and the vote. So it's all yours.
Good morning.
Good
I'm
morning.
Katie McGlynn, Office of Legislative Counsel. So the bill has not changed significantly since you saw it a few days ago. If you remember, at that time, we looked at some changes that were proposed, and the two additional changes that were requested since we met to look at the commission bill was changing it to be a committee amendment. And there was also one typo we found when we walked through it, and so that typo has been corrected. But otherwise, the bill has remained the same. If you'd like, I'll share my screen.
Yep.
And we can just look at that again.
Josh, you had a question?
Senator, yeah, just I printed off the bill this morning off of our Senate page. Katie, would this bill that I printed off, would this be the most up-to-date version, or would this have been in the original form?
Does it say, I don't know what you printed, does it say bill is introduced, or does it say that it's a amendment of the committee?
It says bill as introduced.
Wrong
Yep,
one.
so that is not the most recent version. So the
Okay.
most recent version is also on the committee webpage. That's where I pulled it down from. It's draft 1.1, and it's a committee amendment. And it should have
Up
a
in the
heading.
top
right, I'll
left-hand
put-
corner, it says draft 1.1. The first thing you run into.
I'll play
on it.
around with it.
All right.
Thank you.
Okay. So would it be helpful for the committee if I reviewed the changes that we looked at last time? Do you want me to just show you where the typo is corrected? What is the most useful?
Say review the changes if we could.
Okay.
Okay. So as we discussed last time, if you look at line 21 right here, we had a change of the title. It had been the Vermont Criminal Justice Training Council. That name has since changed since the bill was introduced last year. So now it's the Vermont Criminal Justice Council, and we'll see this one additional time as we move through the bill. The next change was changes to the duties of the Wellness Commission. So in subdivision 4, right here, on line 5, there had been language that said, let's see, effects of trauma experienced by emergency service providers and law enforcement officers. That last clause, and law enforcement officers, was removed from this draft. It was duplicative because the definition of emergency service providers incorporates law enforcement officers, so that's why that change was made. And then in subdivision 5, there was new language with regard to supports and services for the family members of law enforcement officers who experience trauma. So that specific language is to identify gaps and strengths in Vermont's system of care for both emergency service providers who have experienced trauma and their immediate family members to ensure access to support and resources that address the impacts of primary and secondary trauma. The next change was also in the duties section of the Wellness Commission, and that was the addition of a new subdivision 10. And so this language has to do with the specific needs of emergency service providers who identify as women or as Black, Indigenous, or persons of color, or both. So the specific language is to identify the unique needs of and develop culturally appropriate services for emergency service providers who identify as women or as Black, Indigenous, or persons of color, or both, and who have experienced trauma in the course of their duties.
I have a question on this one. So I'm wondering, the language is good. I like what we're saying here, but I wonder if we broaden it to talk about identified appropriate services for based on gender, ethnicity, race, ethnicity, and gender. I think that covers everything that's there, but it might actually cover it differently. What do people think about that? So using just slightly different language. So it would be race, ethnicity, and gender. Ruth, you were worked on this, so.
Yeah, I'm thinking, I'm trying to think what I think of that. I guess I'm not opposed to it, except for, I think two things that I think, just thinking about this off the top of my head. One is that the current languages focuses on the people, and I like that, not just their identity, people who identify, or service providers who identify as. However, the benefit of the language you're proposing, Senator Lyons, would enable us to say race, ethnicity, sexuality, have this sort of like normal, usual list of inclusive and, inclusive list, and without getting too awkward in the phrasing. So I do like that about it. So I don't know if there's, Katie, if you know what I'm talking about, that sort of wanting to stay focused on the people, but also be as inclusive as possible. So I'm not sure if there's a middle ground or not, but I'm not opposed to it, Senator Lyons.
Yeah, no, I see what you're saying. And Katie, that would be a wordsmith that I think would be important. So it would be people based on race, ethnicity, gender, something like that. Or gender identity.
I'm gonna have to play with the language a little bit. I don't have a proposal to solve that, but you want person first language.
Yes, we do. Yeah, I think Senator Hardy's very right in that.
And then are you limiting the criteria that you're looking at, gender, race, and ethnicity, or is it broader than that? Is it
race, ethnicity,
sexual orientation, and persons with disabilities, gender identity, or should we leave it at the categories that you listed?
But let Senator Hooker speak first, and then we'll have that discussion. Go ahead, Senator Hooker.
I was just thinking that your language seems to be more expansive than the present language, but I like the idea of gender identity. And now that Katie's mentioning people with disabilities, I think that we need to include that as well.
Yeah, it doesn't eliminate the categories that are currently there, but I think it does expand it. And when you said disabilities, that really struck a chord. And gender identity obviously does too.
Senator Cummings.
Yeah.
Hi, go ahead. Just it's a discussion. Go ahead.
Okay. I think I like yours because this is law. And when we start talking about groups that we are specifically focused on now, we run the risk of leaving a group that we didn't think of that comes up next year. So I like the, people based on their ethnicity, and see if we can't find a kind of general catch-all or anyone whose special circumstances.
Ooh, I like that.
But as broad, we don't want to say this is a one size fits all. But we may actually find that white male state troopers have special issues.
Yeah.
I think Senator Cummings, I think what you're saying, and I agree, is to try to be as inclusive as possible. And I think, Katie, I don't know if you and Ledge Council has a sort of standard language, but this is something we've wrestled with a lot over the last couple of years. And I think that you might have standard language somewhere or some kind of list that you generally plug in. That
boilerplate.
Yeah, boilerplate. There we go.
Oh, she's going to build boilerplate for the whole legislature.
Yeah, or you could set the standard, Katie.
Yeah. So now if we had acted on my inclusive constitutional amendment last year, we might obviate the need for things like this going forward, but enough said about that. I don't know. Anyway. Okay. Katie, do you have it? I mean,
Yeah,
do you know
I'll put something
talking
together
about?
for you to respond to.
Okay.
But I understand what you're looking for. And then I think we're gonna maybe have a similar conversation when we get to subdivision C1 here. So the
Okay.
top, so subdivision C lists the members of the committee, and the change that was made was to say that the commission is to comprise the following members and include representation by individuals who identify as women or as Black, Indigenous, or persons of color.
So do we want to broaden that language as well, just to?
I think broadening that language may be helpful, but I also think including to the extent possible or some practicable or something like that, because you wouldn't want to, you know, tie the hands of this commission if they can't find the appropriate people. We want to make sure that the commission is functioning, and there are a heck of a lot of people on this commission. So I think saying to the extent practicable or something like that, but making sure that they are, you know, considering that and including that as part of their charge.
That's a good idea.
We don't want to go past Z. I don't know.
We're at X. We need 2 more people. Maybe we'll put one House member and one Senate member. That would take care of it.
No, that'd get it sent to appropriations.
Okay, no, we won't do that. Okay. All
So
right.
just to be clear, the changes we're talking about in C1 don't affect the size of the group. It just means that of the group that we're identifying, we're looking for some diverse representation.
Yeah, as much as possible. Yeah.
Okay. So I will put a change together for you to respond to. And then the next change was in subdivision C1B. And again, this is the second place where we have that title change of the Vermont Criminal Justice Council. And the last change we discussed earlier this week was adding a member to the commission. I'll scroll down so you can see that. We have a
3
member.
pages just to get the committee in. There it is.
The executive director of the Enhanced 911 Board or designee. So that's a new member that was added in the draft that we looked at earlier this week. And that's
All
it
right.
for changes that you discussed.
Excellent. So can I ask you all this question? Katie, thank you so much. It's been I know it's a short bill, but it isn't a simple bill. And it has broad meaning for people. But let me ask the committee this question. If Katie can put together some language for us and get a new draft, we can put it up on the webpage, your new language, and let's look at it and consider, let me know on Tuesday when we get together if you're ready to consider a vote on it. And I know there are people out on YouTube right now who have interests in the bill as well. So if we can have that up on the webpage, can you do it by Monday, Katie? Okay, so
Yeah.
then
We'll have something by the end of the day.
it will hear from people if there's a hue and cry. If there's not, then we'll see how you feel about voting for it on Tuesday. And if it's not Tuesday, we'll vote on Wednesday. How's that sound? Sound good? Good. Wow, wouldn't that be nice? This is one of my one of my favorite bills for a lot of different reasons, not the least of which is how critically important it is to the people who have brought it to us and to first responders. And then after hearing some of the testimony that we've had, it's so meaningful to members of families. So it'll be good. Anything else on this one, committee? Oh. Anything else? So next week, Katie, thank you. I think we're good with that bill. And it'll be nice to have it move. I did get a message from Senator White and GovOps. I think they're going to be okay with the bill. I'll let her know that there's a new draft going forward that'll be out on Monday, and maybe I'll point her in that direction so her committee can have a look. So next week, we're going to be looking at some bills that some of which we've looked at previously and some of which we have not, but the bills that are in our committee. And as a heads up, I'm looking to have the nurse compact bill in front of us again so we can do some work on that, trying to get some testimony on that. Then we'll also continue our work on the flexibility bill and try and get to some closure on that, on everything. Let's hope we can get to some closure on most provisions, maybe with the exception of audio only, and we're somewhat dependent on what the House is doing there. We're also then going to take a first look at a couple of bills. One is the stem cell therapy bill that we have in committee and that we've heard a little bit about. The other is the flavors bill, and we want to go through that bill in particular because week after next, we're going to get a lot of testimony on the bill. And just FYI, a couple things on the stem cell bill. That bill is really very important for consumer protection, patient protection, and now in the time of COVID has become even more pressing an issue. And then on the flavors bill is important for a lot of reasons, but not the least of which it's an equity issue for the effect that some of the advertising and sales of flavored tobacco and vaping products has on African Americans. So we will, and then not to leave out the pandemic, but tobacco use is one of the problems that is associated with the response to the disease. People get much more sick if they're smokers. So I just read another article about that one. So those are some of the things we'll be looking at next week, and I'll try to get some testimony in for us. Again, in the first, we will also be looking at the federal dollars, the December federal dollars, and any guidance. We'll have Steve Klein and Sarah Clark in, Steve Klein from Joint Fiscal and Sarah Clark from AHS. So we'll have a full week, but I think there's some really neat things that we'll be looking at. And I think unless you have questions, I'm going to meet with Nellie a few minutes. We'll go off YouTube and meet with Nellie. I have to do some agenda planning, but does anyone have any questions? Oh, let me ask you this question. Do you need a little bit of time for yourselves before we go on the floor? Yeah, okay. Thank you all. Again, your help, your work on S42 and on the flexibility bill is just great, and I really appreciate it. Thank you. Okay, so hasta luego. Nellie, you can take us off YouTube now.